today is the part 2 of the lupus nephritis talk. The moderator for today is Dr. Irfan Agha. Our panelist, as per routine, I would just request the panelist of the members of the GN team, if they can just introduce themselves, and then we can just probably start. Yeah.
Can I request everybody to mute their Zoom? It looks like that function did not work, so I think so we can avoid any background noises. I'll ask Dr. Agha to say something, take over.
Oh, thank you very much. So are we doing introductions again? So, everybody, welcome to lupus nephritis. We are going to basically do case discussions today mostly. I think we made a mid-air 180-degree turn a few hours ago because we all felt that the panel-based discussion format was a little constrictive and kind of killed a robust discussion and participation by all the members that are all the participants rather than just a few people opining. So I think this is more interactive, so please feel free to jump in, ask questions, or express your opinions. I think without further ado, we can start. Is that right? Or Ahad, do you want other people to introduce themselves, or what's the deal?
Sir, we can proceed as you wish, whatever you feel like it. Usually, हम लोग introduce कर रहे होते हैं, because it's part 2. Maybe we can just start then.
We could probably just start. How's that?
Unless we have new participants जो panel में जो कि पिछली दफा जरा.
Yeah.
So उनका मैं नाम ले लेता हूँ. I'll just introduce because usually the panel, so we've just added 2 more panelists. That is Professor Numan Tarif, who is head of department at Fatima Memorial Hospital, and the other name is Professor Ijaz Ahmed, who works at SIUT. He is professor of nephrology there. So he is the other panelist we've involved. And I think without further ado, Jaise Irfan Sahab ne kaha, but let's move forward.
Very good. So. So like we discussed last time, lupus is a complicated process, genetic predisposition, environmental triggers, a complex interaction between the innate and adaptive immune system, several issues in making this response aberrant, leads to generation of autoantibodies, immune complexes form, some in the circulation, some in situ, and eventually with amplification of these aberrant pathways, we develop tissue-specific disease. And when we are looking at kidneys, we look at a kidney biopsy from a pathologist standpoint. They go through a scheme to pigeonhole the disease process in 1 or 2 or 3 or actually 5 big categories. So the first thing they look for is the presence or absence of active and sclerotic lesions. And if they find that there are active and sclerotic lesions, then you're essentially going towards what we refer to as proliferative lesions. So if more than 50% of the glomeruli are involved, it's called diffuse proliferative lupus nephritis. And if there's less than 50% glomeruli involved, we call it class 3. But if there's no active proliferative lesions involved, then the next thing we look at is the presence or absence of membranous type lesions. And if we do see membranous lesions without proliferative lesions, then that's pure class 5. If we don't see membranous lesions, we're left with mesangial hypercellularity. If we see diffuse podocytopathy with that, then that's called lupus podocytopathy. But if you don't see diffuse lupus podocytopathy, if you're just looking at mesangial hypercellularity, it's class 2. And if you don't even see that, it's class 1. But even in class 1, you'll find deposits in the mesangium. You cannot diagnose lupus nephritis without mesangial deposits. And this is why that is. We went over this last time: normal glomerulus, epithelial cell, the glomerular basement membrane, endothelial cell, mesangial cells. And in class 1, you'll find these black deposits here in the mesangium. That's all you see in class 1. In class 2, you're going to see some proliferation of the mesangial cells. In class 3 and 4, you're not only going to see proliferation of the mesangial cells, you're going to see infiltration of the capillaries with inflammatory cells. Now, we used to call this proliferative lupus nephritis, but actually the proliferation is not a true proliferation of anything. It's just infiltration with inflammatory cells. The only thing that actually truly proliferates are the mesangial cells. So nothing here proliferates. It's just the mesangial cells that proliferate. And so kind of see how this mesangial space and the subendothelial space are actually continuous. So it's pretty straightforward to see when you've got increasing burden of disease, these deposits are going to slide into the subendothelial space from the mesangial space. And in membranous type lupus, you got a slightly different formifruity of the disease, which actually behaves differently clinically as well as prognostically, and we'll talk about that a little bit. And in this, you see subepithelial deposits more than anything else, but you will see some subendothelial deposits. You will see some mesangial deposits because you cannot have lupus nephritis without mesangial deposits. That's the first place you start developing accumulation of deposit material. And these deposits are actually antibodies, complement, inflammatory proteins, so on and so forth. And so you can have a combination of class 3 and 4 with class 5, which is essentially treated as class 3 or 4. And then when everything's fibrosed off, that's class 6, which is essentially an end-stage kidney. So we'd kind of gone over this, and we'd had one case last time where we talked about therapy in detail. Dr. Lanewala had presented a very, very interesting case. And so there was a lot of discussion on it, a lot of interest on what agent to use and what agent not to use. So we will continue some of that conversation today. We will start with a case that Dr. Umar Farooq will present. It's a very interesting case with several aspects of pathology and management which are worthy of a discussion. And then I will have what I can only call as a rapid fire sequence of several cases and some information with them to see what everybody would do in a situation like this. And these are all real cases. So without further ado, I will then ask Dr. Umar Farooq to start sharing his screen, and he will present his case. Umar, I've got your slides loaded here. If you want to use my deck, you can do this, or you can actually share your screen. It'll probably be easier for you.
Yeah, actually, I just added a couple of EM slides, so I found them.
Of course. So I'm gonna stop sharing, and you take over.
So, alrighty, how many? Okay, here we go. जी अस्सलाम वालेकुम सब लोग क्या मेरी देख सकते हैं जो प्रेजेंटेशन है स्लाइड डेक जो है अच्छा तो जो केस है ये इस वक्त ये पेशेंट जो है ना ये एडमिटेड है और ये कोई मतलब आई डोंट हैव ऐसे कोई कंक्लूजन नहीं है मेरे पास लेकिन ये है कि लॉट ऑफ आई वुड से ह्यूमिलिटी कि भाई ये लूपस जो है वो it has such a wide spectrum of the disease and it has so many different flavors और इसकी जो presentation है वो किस तरह से mild से लेके बड़ी severe हो सकती तो I may not have all the best answers I may actually need help from all of you कि इस patient के साथ हमें क्या करना चाहिए लेकिन I will present and start my presentation so 18 years old, black male. He is African. So, इसका father जो है वो immigrate किया किसी African country से. So, he's a lawyer actually. He works in Baltimore. Excuse me, man. I'm just recovering from something common cold too. So patient has high creatinine and potassium in urgent care visit. No other complaints. No past medical history. Swelling was the only complaint. And he was nauseous and had vomiting. Excuse me. So he takes no medication, no alcohol use, young guy, 2 other brothers, they are in the boarding school. He was finishing high school and about to start college. Koi family history nahi hai. Blood pressure was high when he came in or edema was on the exam. So these were his labs, BUN 92, creatinine like almost 8, potassium was 6, bicarb 16. So you can see that he has full-blown renal failure. Glucose is 103, hemoglobin 7.2, platelets 171, He had peak T waves and also proteinuria with urine protein to creatinine ratio 2.5. When he came, his BP was 150s to 170s, edema in the exam noted, labs, very high titer of ANA, 1:2560. So in our hospital, anything above 1:80 or 1:160 is positive. C3 was 51, C4 is 4 and low. DSDN is positive and then titer is very high, it's 3,460. Anti-Smith is 15 and normal is less than 20. Anti-histone is high, so normal is less than 1, his is 10. Anti-Jo1 is 32, and this was actually not high. So not only that he has ANA positive, he was also ANCA positive with perinuclear pattern and 1:1280. This was anti-proteinase 3 negative, but anti-MPO positive at a titer of 200. And his anti-GBM was indeterminate. So as you can see that, you know, how much autoimmunity is there, that there is so many antibodies, there is so much background noise, some specificity, a lot of, you know, sensitive antibodies present, and full-blown renal failure. Now, maybe I can
may I
ask.
ask a quick question? This anti-MPO, is that on an ELISA or is that still on an indirect immunofluorescence?
I think this is on ELISA.
Okay, very good. Thank you.
So we do that pattern. So for the immunofluorescence, but then this is, so we always send this specific ANCA all the time to make sure that, you know, if we have ANCA, we want to make sure which ANCA it is. So he had a kidney biopsy done, and I don't have the light microscopy because our pathologists, they haven't taken those pictures, although we presented this in the conference. But I got the EM because EM, you know, came on CD, and I have some pictures I will show you. So this was like, you know, like really very active class 4 DPGN, diffuse proliferative and crescentic GN. So 35 glomeruli were there. There were cellular crescents, and few of them were circumferential, like, you know, really, you know, kind of a full moon crescent, not just like half moon, like not crescent. They were everywhere. There was mesangial expansion and mesangiolysis, so a lot of inflammation there. Global endocapillary proliferation and basement membrane duplication in some of the areas. 1/3 of glomeruli showed segmental scarring already. And there was 1 or 2, those fibrocellular crescents. So different stages of the lesion, as you can imagine. There were the periglomerular arterioles showed no evidence of TMA or hypertension changes in the kidney arteries. There was a lot of interstitial inflammation, which is composed of lymphocytes, plasma cells, and scattered eosinophils. There was a periglomerular granuloma noted. The interstitial space was widened by the inflammatory infiltrate, but there was very little fibrosis or tubular atrophy. So all these lesions were acute and active. And the immunofluorescence show the classic full house. So this was not pauci-immune, this was very full house. In the order of, you know, intensity, C3 was very prominent, IgG, IgA, and IgM were all there. So EM, and I think this is kind of a zoomed in image. We have our pathology colleagues as well. If let me see if she's on the line, and I can get some help.
Dr. Mubarak is there. Dr. Mubarak is
here. Perfect. So this is EM, and this is how it's described. So 2 glomeruli were there, both had crescents. There were mesangial deposits, as Dr. Agha mentioned. There were subendothelial deposits, and there were also subepithelial deposits. So, and then podocyte foot processes were extensively effaced, and a few tubular basement membrane deposits are noted. In summary, the biopsy demonstrated a diffuse proliferative and crescenting, you know, GN. They thought it's lupus class 4 active and chronic lesions. But they also made a comment about overlap lupus nephritis and ANCA-related GN cannot be excluded. So this is the picture. Dr. Mubarak, do you want to say something about this EM picture?
I think Dr. We have lost his connection or
Okay.
something. I
That's
saw
fine.
him in the list and he's not here.
I think he's having connectivity problems because वो WhatsApp पे भी कह रहे थे. I think उनके local internet का कोई problem आ रहा है. Otherwise,
ठीक है. तो I maybe we can just ये थोड़ी सी zoomed in was वाली picture है, तो you are seeing. So is this the basement membrane? Everybody can appreciate, right? The arrow you can see. I think this is the endothelial side because I see those endothelial cells. I would see a RBC or something like in ये इतना ज़्यादा zoomed in है कि वो सिर्फ वही चीजें focus में है. So I will show you more pictures where deposits are very obvious. Irfan, you want to say something?
Yeah, I think, if you jump here 477 Likova, if you follow that up and to the left, you can actually see that basement membrane loop. And inside of that loop, jo ilaka nazar aa raha aapko, which is kind of tracking down, that's the mesangium. You can actually see this very large deposit on the other end of that hairpin. On the other side of this big loop, you can see a large deposit there. And you're exactly right on the endothelial cell, and it looks like the capillary loops are full of stuff there.
So if I go to next,
Omar bhai, what about C1q? Was that positive?
C1q?
Yes.
अच्छा, वो उसमें जो मैंने जो उसकी रिपोर्ट कॉपी की है उसमें I see C3 IgG and I don't think C1q का उन्होंने they mentioned it. So ये more pictures हैं. So I think on the left hand side this is kind of maybe थोड़ा सा दूर से picture है, zoomed out picture है, so you can track the basement membrane. But when you and on the right hand side, this one you can see this is the basement membrane you can track, right? So this is probably endothelial side. This is where the mesangium and all the epithelial side, and or this is a picture of mesangium, I think. Anybody can see any deposits? Irfan, if you can, I can show. If not, the next picture may the deposits are prominent.
Sure. So your left side of the picture, that's actually a very high magnification picture. So you're actually seeing, you can't see my arrow, but you're seeing these intracellular little vacuoles and vesicles in there. On the right side, it's kind of a little bit of a zoomed out picture, but still it's pretty close up. I'm trying to look at this picture. I'm seeing some deposits, but it's not like barn door deposits here. So let's go to the next slide.
Okay, so this one.
Yeah, so here you see deposits. There you go.
So these are, this is very prominent, and I think on this side, this is all, these are all deposits, and this is the basement membrane, which you can see it's tracking.
Right. So on the left side, what you're seeing is, so since I don't have my arrow here, so if I move from the right margin of the picture towards the center, what you're seeing here is the basement membrane, kind of sort of about 1/3 of the way through, and then you can see some subendothelial deposits there. But on the right picture, you're seeing big, bulky, large subendothelial deposits, very, very prominent everywhere. So this is very remarkable. So these are large subendothelial deposits here.
So question, I think since we discussed treatment last time, so young, 18 years old, young boy, young man, who this is the first presentation with bad renal failure. I showed you the biopsy, I showed you the pictures. How would you like to treat it? And please, anybody can, chime in. It's not only the panelist. What would you do?
So I think before we go into treatment, Omar, if I may butt in, let's ask a couple of questions. This is a very, very interesting case. What do people make of the double positivity? Very high titer ENCA in an MPO pattern and high titer ANA and dsDNA. What does this patient have? Does he have lupus? Does he have ANCA-associated vasculitis? Does he have both? And when you see both ANCA and ANA positive in this manner, what are the things that we should think about or worry about? What is the first question we should ask in a patient like this? I think the first question you want to ask is, what is their med list like? The commonest reason when you see high titer ANCA and ANA positive, and this can lead to kidney burning disease, is some drugs. So the drugs that I worry about always in a situation like this are hydralazine, xanthine oxidase inhibitors, and anti-thyroid medicines. So propylthiouracil, methimazole, carbimazole can all lead to double positivity. One other thing that can do this sometimes is cocaine. So any indication that any of that was going on, Umar, in your patient?
Yeah, so we took a very detailed history of that initially, and I met him as well in the first round before the biopsy was done. No, I did not. So he was not on any medication. He is, kind of very bright honors kind of student who is, finishing the high school. And he was very upset that how COVID was, has delayed his graduation and different things. And so I had I asked those questions, the drug questions very openly, and there was no drug history, and he was not taking any drugs, like no over the counter, no nothing. He just imagine, like a young 18 years old who is so worried that he is staying in the hospital and he has to miss his school and his next trip to the college. So, family, very educated family. Father is a lawyer. Mother, I think she works in social work arena. And then father used to drive to Washington, D.C. And I think, so they lived somewhere between Hershey and Washington, D.C. So no, and then two of his brothers were at boarding school, but he was with his parents. So other thing, if he's at the boarding school, you can imagine that if he's doing drugs. So the answer to your question is no. And antihistone was positive. So I think, so that's why we took this history, but we didn't find any clue. What is it you want to say something?
So, regarding this drug abuse that may be discussed regarding cocaine, there is a myth that lamamazole is adulterated in USA with cocaine. So is there any experience of it in that kind of situation with anybody situated in USA? And secondarily, once the histone is positive, usually if it's drug-induced SLE, anti-DS DNA is usually not that.
Yeah, no, you're right. So I think that was considered. So he has very strong positive anti-DS DNA. His complements were low too.
And second thing is, there was also reduplication of the membrane, which is a testimony that there was something going on before. So it wasn't something that the crescentic gene is the only thing that presented. Before that, there was some kind of chronicity going on. So what I would assume that the patient was already having glomerulonephritis going on, and there was a tram tracking, and then there was a super added event, maybe exposure to the nuclear proteins and all that. And I had a question associated with it. We had a patient like that, young female, in fact, 2 patients last year, and they had some type of complement deficiency. The dsDNA wasn't that positive, but can a low C3 precipitate so many antibodies when the basic disease is the low C3, which has precipitated multiple antibodies and SLE-like syndrome maybe?
I think these are all good valid points, and there is definitely something wrong on his complement side. So any other comments? Anything else, Dr. Aga? You have one question. You said you have 2 questions.
Yeah, so no, I mean, the first thing is, I just like to, develop an approach. So if no drug was involved and this is indeed true positive lupus and ANCA double positive, then what is driving the guy's pathology? Is it lupus? Is it ANCA? Is it both? How do you tell?
So the findings on the biopsy, I think they were more suggestive of lupus driving the bus, because where the deposits are, how the immunofluorescence looks like, and how the vascular compartment did not show something. And I did not see a comment about fibrinoid necrosis, which you probably will see mostly in vasculitis. So I personally felt that the lupus is the driver.
But the thing is, if the lupus is the driver, C1q should have been positive. So what we observed in few cases with C3 deficiency and complement deficiency leading to multiple antibodies production and a picture like that with overlap syndrome, it may be so that the C1q is somehow not that predominant when C3 deficiency or some complement deficiency is actually led to SLE and SLE-like syndrome. There are almost 26% chances of a chronically C3 deficient patient to develop an SLE-like syndrome, which doesn't fall into a complete category and doesn't have a uniform criteria of a diagnosis. At least that was the literature I came to know about.
Okay. Anybody else wants to comment this and then come up with a treatment approach? So based on the two answers we gave.
When Dr. Ejaz here, we don't necessarily see C1q deposition all the time in active lupus nephritis. So the absence of C1q should not be taken as an evidence against the diagnosis of SLE. That's my thinking. That's what we have seen here in Pakistan.
So C1q will be deposited if you're doing the classic antigen antibody reaction leading to fixing the C1q and then RNS and then going down the C2 to C4 pathway. So that's your classic pathway. But there's another ficolin which can be fixed by antibodies in the lectin pathway, which will bypass C1q, and you can still have antibodies that fix complement through C3 from the non-alternate arms of complement activation, but you don't necessarily need C1q all the time. Dr. Aurangzeb is correct. C1q is a very strong indicator of lupus-like activity, but its absence does not necessarily exclude lupus, because there are other ways in which lupus antibodies associated with lupus can fix complement.
I think in the chat we had some suggestions. IV cyclophosphamide plus steroids. So that's one of the.
Hello.
Yes.
Hello, Dr. Umar Farooq. It looks like lupus plus ANCA overlap syndrome. No, that's what it looks like that to me, with predominantly activity plus also there is some scarring. I think one scar, the scarred glomerulus. No, it looks like that.
I mean, I think this is what our pathologist also mentioned in the final comment, that if I go back a couple of slides.
Like an overlap syndrome.
Okay.
Yeah.
So they said that an overlap lupus nephritis and ANCA-related GN cannot be excluded. So I think we have at least, the initial jury set about the diagnosis. So again, I think that treatment, so I'm getting the responses about cyclophosphamide. Would that be a good option here? Okay, I see one or two nods, yes. So that's what we did. I think we gave him a gram, like, the pulse solomedrol. I think this was probably given before even the biopsy was done. He got IV cyclophosphamide on August 7th. So this was like, a couple of months ago. And then he was discharged with dialysis, oral prednisone, 60 milligram once a day, amlodipine, because he remained hypertensive. He was on Bactrim for PCP prophylaxis, and he was given hydroxychloroquine at the request of rheumatology. So next, he came back on 9/6, so September 16th. So the first admission was early, I think in the August, so then September 16th. So this was around the time, a little bit a week over, when he was due for his second dose of cyclophosphamide. When he came in, he developed new onset seizures. His blood pressure was high on arrival, 161/120. Given the distance, so when we discharged him, he was discharged to a different nephrology group because the dialysis unit was close to patient's home, and that's like an hour away, and we don't cover there. Blood pressure on dialysis in the preceding few sessions were like 140s, 150s, but the diastolic was not in 120s. It was like 90s to 100. So by the time he developed new onset seizure, he was very hypertensive. His heart rate was 82, his temperature was 36.9, his creatinine was still elevated at 7, BUN 45, his hemoglobin was 10.8, and his platelets were 53. So I will keep, so the neuroimaging, because of the seizure, he got intubated, and he's on neuro ICU. So the MRI actually showed finding of the PRESS syndrome, which is posterior reversible encephalopathy syndrome. So then there was another MRI done 2 days later, which showed some restricted diffusion in the right internal capsule, central pons. And then, they were concerned for acute infarcts in this young man. So they also, radiologists made a comment that the PRESS is rarely associated with acute true infarcts, although hemorrhagic PRESS has been noted in the past. So they thought there may be lupus vasculitis or lupus cerebritis going in the brain, in addition to the hemorrhagic PRESS, which they saw originally. So they again thought that there may be an overlap between two. So he started in some sort of overlap in the kidney. Now there is the overlap between these infarcts, hemorrhagic PRESS, and lupus cerebritis. So I think he had another CTA, brain and neck, and he was noted to have multifocal stenosis in the interior and posterior circulation. So there were, they thought this is either vasculitis secondary to lupus, or they call it reversible cerebral vasoconstriction syndrome. And they also considered some vasculitis, this is radiologist mentioned, infectious vasculitis. So he had an LP done, which was negative for infectious etiology. So a young man, 18 years old, who walks in, no past medical history, he was diagnosed to have kidney failure, dialysis started, treated for overlap syndrome. And now a month later, he has new onset of seizures. He's intubated. He got, a trach to the point because intubation is prolonged because he's not waking up. And now there is PRESS syndrome, there's hypertension, and there is lupus or cerebritis or vasculitis, according to radiologists. So this was the hospital course, and these were the same slide which I made last week because we were up to date until that time. And so again, I think here, I would like to summarize. So admitted, MRI showed PRESS, then he went to the ICU, the brain showed edema, so they gave him some hypertonic saline, then he got dialyzed, MRI showed vasculitis, he was dialyzed again. Then there was an echocardiogram which showed normal LV size and systolic function, EF 75%. I think echo and cardiac workup was important in the midst of the strokes, but there was pericardial effusion without any evidence of tamponade, and the effusion was very small. He was EEG did not show seizure activity. He became anemic. He needed blood transfusion. And then I think at some point the radiological study started to improve, and then he underwent tracheostomy. So the neurosurgeon said that it's lupus vasculitis with hemorrhagic posterior reversible encephalopathy syndrome leading to acute seizure disorder is the prevailing diagnosis. The rheumatologists write the same note that patient during this hospital stay, I want to make sure that when he came in, because we saw these findings, he was really given IV salmeterol 500 milligram twice a day at the request of neurologists, considering this as vasculitis, and he got several doses of that. So they said that PRES is the most likely diagnosis because how he presented, high blood pressure played a role. There was some case reports of cyclophosphamide causing PRES syndrome, but there were very, a paucity of data on that. But the other objective data from rheumatologist standpoint was that patients started to improve after the initial diagnosis, and his markers decreased. Actually, his double-stranded DNA came really down from above 3,000 to now 54. His C3 is now 85, and normal range is between 90 and 180, and actually increased from 50s range, and his C4 is now normalized, and his ESR was 4. So they said that with all this doesn't seem to be active lupus. So they thought that just back off on immunosuppression, and then this is just PRES related to high blood pressure. Neurosurgeons think that this is PRES related to high blood pressure, but also lupus in the brain. So what do you think? I mean, I think we were puzzled, and this was my last slide until a week ago, and I had a new update which I just added, which I will update afterwards. So maybe I will stop here and ask your opinion as what do you think is going on, and have you seen this situation in the past?
Yes, we have seen this patient. In fact, the patient that I was talking about, the one with C3 deficient and double positive patient, she almost had the same story. She again presented to us with the provisional diagnosis of lupus erythematosus, and neurologists, and we were thinking on the same lines. If PRES, we should get the immunosuppression on the higher side or we should decrease it. The parameters were improved in my case too, but lupus erythematosus was resistant. And there was another discussion back then. In CSF analysis, should we look for interleukin 6, and does that help? That may help in lupus psychosis, but does that help in these cases? I don't think it was mentioned if it was done in CSF analysis or not.
So the CSF,
I don't know the answer.
Yeah, the LP which we did, it was focused on infectious causes. I mean, I can go back and look in the chart. I was unable to pull his chart from home today for some reason. So otherwise I could have given you those updates because I was trying to add some more updates on that.
Anybody having experience of interleukin 6 in CSF as a tool for helping in diagnosis, in what way to go? Increase immunosuppression or decrease immunosuppression? If anybody has an answer, I would like to hear that.
Yes, Dr. Ijaz here. We have seen SLE patients suffering from PRES as well as territorial infarct. So in this case, it is really very difficult to say whether the SLE was to blame for infarct as well as, or whether ANCA has got something to do with it. And the other thing is, I think it was mentioned that his platelets counts were 70,000. Was it looked for whether he developed anything like thrombotic microangiopathy, which can also cause PRES as well as small infarcts?
Thank you, Dr. Ijaz. I think you picked something which was, I think it's a good goal kind of, focus. So when he came in, his platelets were 50 something, and everybody, initially blamed it to the cyclophosphamide. And I said cyclophosphamide was given too far, like it's more than 14 days and more than even a month ago. So, but his first platelet was low. It quickly actually came up to low 100s. So there was a peripheral smear done. There was haptoglobulin. There was, workup for any TTP, TMA. initially it was not positive, and even on his kidney biopsy, this was not present. But actually, that is the new twist to the story which you just mentioned. And I will update in next slide or two. But any other comments about, this kind of the debate between whether this is pure press just from hypertension or lupus is in the brain as well? I think I'm convinced that this is definitely, some sort of inflammation in the brain related to his underlying disease. I think this is more than just press. So that's where I kept pushing for, to make sure that we have appropriate immunosuppression on board. We don't need to kind of over immunosuppress him, but there should be appropriate immunosuppression on board. Dr. Tarif, do you want to have any comment on that? I think Ali, his camera just turned on.
Yes, because I wanted to raise my hand. I just wanted to comment on this, that we have seen neurologic complications with lupus, not along with NCA. I can't recall any such case. My comment was about press, that whenever we see press, it's sustained high blood pressure for some time. I mean, in cases like this, when you see some cerebral edema and you just label it as press without monitoring very high blood pressures over a sustained period of time, that is something I can't digest.
When you say sustained
so
period of time, how long of a duration do you think is sustained? Like a few months or a few weeks, or
it has to few days or very high readings, high readings, like hypertensive emergency kind of thing for few hours. But those are the times when you have to manage those blood pressures to keep that patient alive.
Mm-hmm.
It's that high blood pressure.
Yeah, and his initial blood pressure for the first several days was high to the point that he needed intravenous drip for nicardipine and all those blood pressure.
Oh, he did.
Yeah, he did. So initially,
I missed that.
Yeah, I think I zipped through some of those details, but he needed that, and then a few days later, his blood pressure. So volume was a contributor. So when I saw him, I dialyzed him aggressively, and actually his blood pressure really improved after aggressive dialysis, and then we backed off on his antihypertensive to the point that he was just on 1 or 2 medication throughout. So he had very high blood pressure when he was there in the hospital originally.
So he could have rest.
He could have that. So maybe we can keep moving, because I just don't want to spend all the time. So we discuss about the diagnosis. So this time he got more steroids, as I mentioned. And then there was a debate whether we give him the cyclophosphamide, his monthly due, which was due by the way the day he got admitted. This was already scheduled. But I think because of looking at overall, I think people felt comfortable with CellCept. So they added CellCept to make sure that CellCept on top of prednisone is continued, and other supportive care. So October 8th, so this was, I think this Friday, I got an email from my colleague that there was another peripheral smear was done. And this was more recent, like in the last, couple of days. Now there are schistocytes. There is still anemia, and there is thrombocytopenia in the 90s and low 100s. It was not in 50s. That's what and his LDH was high, but haptoglobulin is not low, although his bilirubin is high. The question is what to do next. So I think this is my last slide, and I don't know the answer, but the eculizumab is thrown here. Is that an option? If he has developed TMA as a result of lupus, what should we do? Should we plasmapheresis him, give him more steroids, give him eculizumab? So those are some of the options which are being discussed over the weekend. I will stop here and let the experts to help me. And if anybody else, please guide us how we can take good care of this young man.
We have used.
Sorry. Sorry, go for it, sir. No problem. Go for it.
We have used plasmapheresis in patients with SLE and thrombotic microangiopathy. I have no experience of using eculizumab. It's not available in our country. So I would have done plasmapheresis in this patient.
So thrombotic microangiopathy is described both with lupus as well as with ANCA-associated vasculitis. So when it gets to this point, I mean, this shows us consistently, this has shown us that there's been ongoing antibody-mediated activity and ongoing endothelial damage, probably complement-mediated, probably through non-complement-mediated issues. And so one observation and then one suggestion in this particular case, the observation is when you gave them MMF, at that point, would there have been some utility of giving them rituximab rather than MMF? You already had given them cyclophosphamide, there's dual positivity, and you would think that you want to, and the ANCA people that kind of tend to respond to rituximab, not ANCA, lupus people that kind of tend to respond to rituximab may drop in the bucket where you've got dual positivity, or even when your ANCAs are negative, if you're seeing fibrinoid necrosis, a lot of crescent formation, those are the people that might actually respond a little bit to rituximab. So I would have considered rituximab very, very closely at that time. That's one. And at this point, if you do have eculizumab available, that's kind of what my go-to would be. I would give them eculizumab.
So just, I think I was actually, on service, and the one day I started, the idea of vitamin R. Sorry, Aurangzeb. So I suggested rituximab before CellCept was added for the very same reason. And I think I had a discussion with neurologists as well. So so sometimes, our patients are, the primary service, they have a lot of say into their final, and the neurologist who's taking care of, he's a good one. So I actually suggested rituximab right in in the very beginning. And then I had to come off of the service for some personal situations. I needed coverage. So that idea did not get any approval, but we are actually considering eculizumab now for sure. So he might have received a dose of eculizumab over the weekend already. We didn't want to delay it any further, because I think once we saw that, the nephrology group actually pushed for eculizumab, and there were some other markers. I'm sorry, I couldn't open his chart today. Otherwise, I could have copied his labs and everything for the group. But we are giving him eculizumab, and I'll be happy to update everybody what happened next. Plasmapheresis we did not do as of yet. Although I have done plasmapheresis in the past in a patient who had lupus anticoagulant and presented with TMA, but in this situation, I think we are going straight to eculizumab.
Well, in Pakistan, because we don't have eculizumab, I would go for rituximab. I don't want to be the devil's advocate, but that's it. And with that, MMF is not a bad option, but plasmapheresis is something that we have to do considering cystocytes are positive. So we need to couple that rituximab with plasmapheresis in a careful manner, because we don't want to freeze rituximab. So there should be at least a 48-hour gap in between the two if we need to really get them close together. But yes, in a patient who is having so many antibodies all around, we want to get hold of the plasma cells in some way, or T cells. So I would definitely go for rituximab. And to add to that, there is an incomplete data, and it's not really convincing, but there are some case series in which double positive patients were given cyclophosphamide with rituximab. And they have shown a little better result, not really to the extent that I can advocate that here.
So Aurangzeb, may I ask you to highlight I know we may have some trainees in the group as well, the gap between the dose of plasmapheresis or the plasmapheresis, because this patient is on dialysis. If you want to do plasmapheresis, then you want to also do rituximab. So please elaborate your answer about the time difference or the gap between the dose of rituximab and plasmapheresis, and why is that? Just for the sake of our trainees.
Well, usually it is said that it takes 48 hours to 72 hours for rituximab to actually bind to its original site CD20. So we don't want to freeze rituximab during that period.
Exactly.
So in general, we want a gap of 2 to 3 days before we can do the plasmapheresis. So what we do is, in such situation, we give a session of plasmapheresis. IVIGs are indicated in any case. And then we give rituximab.
Yep.
And then if we can manage the time of 48 hours, so we'll squeeze the gap and then do another one.
Yeah, I think you're right. So we do something similar for the AMR treatments. Your rituximab is the last man standing to make sure that we don't freeze the rituximab out. And I had a patient who we had to continue plasmapheresis because of the FSGS recurrence. So we made sure that gap was there, because you don't want to infuse this drug and then just take it out with the plasmapheresis. Thank you.
One more thing, I think there was a question on chat that does rituximab lead to PRES? And that's true. There are case reports for it, but I don't remember most of the immunosuppression that we use for SLE. They are somewhat related to PRES in one way or the other. There have been case reports with almost all the immunosuppression that are in use. So I don't know, was that a situational association, or is it actually a cause and effect relationship that we are associating rituximab, MMF with PRES syndrome?
It sounds like there's some off-target effect of B-cell depletion, whether you do it through cyclophosphamide or MMF or through rituximab, and sometimes you get these weird neurologic syndromes. And this is why thinking in terms of using more specific B-cell therapy like obinutuzumab, etc., may work on that. But you know, these things do happen, but we still have to treat the patient. And it doesn't mean that if you're getting PRES because of lupus, you're also going to get PRES because of rituximab in that particular case. And like Dr. Aurangzeb said, these are case reports, these are association studies, causality is another thing, but there seems to be some thread there with off-target effects of B-cell depletion. Those are all good points, and that's a very, very difficult case. So best of luck to you, and best of luck to this very unfortunate 18-year-old. So one final question, where you said he was of African descent. Do you know West Africa or East Africa?
Good question. I wish I had. Basically, I mean, I think I asked him, so I don't recall whether this was Kenya or Nigeria or.
Because if he's if he's Kenya, he's okay. If he's Nigeria, he's not.
Okay.
Because he may have the APOL gene and his kidney is not going to do well if he's from Western or African origin. If he's from Western or African ancestry, he's got about a 15% chance of being homozygous for APOL1, G1, G2 mutations. And if that be the case, then his kidney is not going to come out well at the other end of this very, very severe illness. It's a remarkable case. Okay. Should we start to the next, move on to the next part of the talk?
Yeah, please. I think there are some questions, but those are being already answered.
Yeah, okay. I think I'll have this feeling.
Yeah, sorry, just one question, which is actually keeps on coming up. So I just want to know, why are you sort of, why are we advocating rituximab over plasmapheresis at the moment? Because
No. That's actually, no, that's probably not the correct message. So my apologies, and that if that is the message. No, what I was talking about was that before the TMA had precipitated, when this patient was sick, came back again, had neurologic sequelae, and the question was, how should we bolster his immunosuppression? If I were treating this guy, I would have given them rituximab up front. I would actually have stolen sort of a paradigm, not from lupus, but from ANCA-associated vasculitis management. I would have given them cyclophosphamide and rituximab together initially, because this is a devastating illness. And what he has is essentially uncontrolled lupus. So with that presentation in this young guy, you want to upfront hit them with a sledgehammer, otherwise you're going to run into trouble, as we did. But when the question was, how should we bolster it? We've given him more steroids. Should we give him more cyclophosphamide, or should we give him a fairly baby dose of MMF? Then at that point, what I would have done, this is a kid who's dying, I would have given them a stronger dose, either given them more cyclophosphamide. But if the thinking was cyclophosphamide is in some way precipitating the press, then I would have given them rituximab at that point. Now, when TMA has already developed, that's, you know, the horses are already out of the barn at that point. You've got now not only deposition of these antibodies in the kidney and damage to the small vessels, causing a small vessel vasculitis through the ANCA pathway, you now also have widespread endothelial toxicity, endothelial damage. And at this point, you have to protect the endothelium. You have to shut this thing off. And eculizumab is probably a very effective way of doing it. Short of that, if you don't have eculizumab, then what we used to do, 20 years ago when eculizumab was not available, we used to freeze these people. So if you don't have eculizumab, you freeze them. If you do have eculizumab, you deploy terminal complement blockade to protect the endothelium and also protect the tissues from antigen antibody driven complement activation.
So
I hope that is clear. I hope that is clear now.
Yeah, thanks.
And one more thing that I wanted to add, the similar case that we had, I don't want to discourage the future prospects, but the thing is, we gave her rituximab, plasma freezed, MMF, but she is ESRD. And guess what? C3 is still below 50 persistently. She is ESRD for the last few months now. And there isn't any facial lipodystrophy and everything else. The fundus is good.
Right.
So it's not
Right.
like.
Right.
But just, I had a quick question. Is it okay to ask?
Yes, please go ahead.
Yeah, this is Farooq Qureshi. I'm a nephrologist in USA. So, so this is a great case and discussion. And just sort of going back to, I'm sort of going back to the original admission. I joined like 5 minutes late, so I might have missed a little bit the beginning. But so going from a teaching standpoint or sort of a learning standpoint, the first admission when this patient was initially treated with cyclophosphamide and pulse steroids and IV and IV cyclo. Mm-hmm. So what was the plan at that time in terms of the subsequent, besides the 60 milligram prednisone, were you going to continue cyclophosphamide, PO?
Yeah, that was the plan. This monthly IV Cytoxan was the plan. And he actually was scheduled to get the Cytoxan the day he got, I think the day or the one day after he got seizure. So that the plan was to give him monthly Cytoxan along with prednisone 60 milligram.
So he never got the second dose then. I mean, so he was discharged, I guess, on dialysis, I understand. And for a month, he was pretty stable. And
yes,
then he came.
So yes, he was doing okay. No admission in between. The day he was scheduled to get his second dose of cyclophosphamide, he actually was transferred via ambulance.
Okay, so I'm just trying to think, like one of the points which I guess Irfan had mentioned about, maybe treating them upfront with cyclophosphamide and rituximab both. I mean, I have never seen that or done it, but that's an interesting thing in terms of although that initial admission, the person did not have TMA, I understand the platelets, and there was no other signs of thrombotic microangiopathy in the original admission.
Mm-hmm.
Now, the question is that the second admission, all these findings, the press, the TMA, is this, as Irfan is saying, I mean, this is just simply uncontrolled lupus, although the titers have improved from a lupus standpoint, or are these medication-related, problems? And if in both the press and the TMA, I mean, because it looks like in the second admission, this patient got a bunch of stuff, all these IV pressors and, hydralazine, etc. So, I mean, the question really is that, is this the baseline disease, or is this, the treatment related or treatment maybe precipitated events? And in that case, does the management in terms of eculizumab or pheresis or whatever, would that be affected buy that sort of hypothesis, or you know?
My personal, take on this case is,
I don't necessarily know that you have the answer. I mean, I'm just trying to.
No, I don't have the answer, but I can share my opinion. I think this is his disease, is driving. It may be multifactorial because there was a volume component to his hypertension, but you may see press, but you shouldn't see all those other findings on the neuroimaging. So I think this was his original disease, which is really, not properly controlled. And then in like a multifactorial, so the other factors are adding up. But I still believe that the original disease is one of the driving force and the main driving force. And even the rheumatologist was concerned that this is not the original disease. I am concerned. Hindsight is very bright, but I think it's really when you have to sometimes take the decision in the middle of it, because I kept saying that, like, we need to go increase the immunosuppression. And I think there was resistance to go to decrease the immunosuppression because of some infection issue like pneumonia and some other, and even once those were cleared. So I think I was convinced that this is his underlying disease. I mean, I'll stop here, but again, like, hindsight is bright, time will tell.
Yeah, I mean, I understand that. So I think the second mission looks like whatever the management was pretty appropriate. But sort of the take-home point, maybe I just want to clarify from Irfan and others that is this a right take-home point from this whole case discussion that any patient with an overlap syndrome, is there any evidence, or is it just I mean, is opinion based that we should treat them with two immunosuppressive drugs besides, in addition to steroids? So kind of like a transplant type rejection management type kind of management. Is that the right take home point? That
yeah, I would just be very, very careful in how we parse this. So, so the paradigm that I had when Umar was presenting this case, the paradigm I had, I was thinking about it, this is a very difficult case, young person with terrible disease. How would I do this differently? So if this was just lupus, if the ANCAs were completely negative, I would do exactly what was done. I would, do intravenous cyclophosphamide and pulse steroids and all that. When you have, and I respect ANCAs in lupus because they're bad actors. When you have such high level ANCA in there as well, and you've got crescents all over the place, circumferential cellular crescents, you have to then start paying attention to that ANCA as well. And this is entirely opinion based. You cannot parse this in any trial because you can't have a trial for this. The only thing that I would have probably stood on would be that this would be something like a rituximab based regimen. So if you remember the two big trials for rituximab that came in an ANCA-associated vasculitis, one was RAVE, which was kind of less severe disease, and you just used rituximab. But the rituximab, the Rituxvas, which was published in the same journal, same NEJM issue, was rituximab, where there was a combination of cyclophosphamide and rituximab for those patients with more severe disease. And I think that's kind of where I'm bringing this out from, that this was a young kid with very, very severe crescentic disease and very high double positivity. Is this person the same as your other diffuse lupus proliferative nephritis with crescents? And, maybe they're not the same disease. Maybe there's something qualitatively different about it. So the question then you ask is, okay, how much can I harm him by giving him an extra dose, a dose of rituximab up front as well? And my thinking in those circumstances is, when you look at the rituximab cohort, we didn't kill a lot of people with infection. So it can be done. Now, the reason I said we wanted to parse it carefully is that this is add-on therapy. It is not multi-point therapy, which is now becoming a thing in lupus. And we'll talk about that a little bit, because multi-point therapy like in transplant patients, is therapy with, which targets different sequence points in the immune response. But Ferg's point is well taken. This is opinion driven. This is not coming out of any trial, nor will there ever be a trial on something like this. This is one patient that we have seen, and none of us will see another patient like this in 5 or 10 years. These are rarities. So the only question as a clinician that I was trying to answer is, okay, I've got this guy, we've put him in one box that he's got diffuse proliferative crescentic lupus, but is that all? Does he have something else? And is the box that we are putting him in a little inappropriate, or maybe not quite the right fit? And that is why if I were treating him, I would have, upfront given very, very strong consideration to a dose of rituximab as well. But this is opinion, and people may have very different opinions, as they should. And that's the whole point of having this conversation, that clinicians will do things differently, especially when we don't have a lot of strong data guiding us. So.
Yep. And I think on rituximab, you know my opinion, but the thing is, my question is regarding CSF analysis. Does interleukin-6 help? Is it data-free zone? We received that patient that I was talking about a few months back. By that time, there wasn't any convincing data that interleukin-6 in CSF does help in making decision towards for lupus erythematosus or against it. Anybody has experience? If doesn't, nobody has experience, I would request Dr. Umar to discuss with the neurologist and then come up with some answer. You may be getting some more data.
Yeah, I can look into it. I don't know the answer to your question.
Okay, shall we move forward? We're kind of running behind on time again.
Sure.
All right, very good. Well, first of all, I appreciate a very, very good discussion. This was very entertaining and educational. So the treatment paradigms for lupus have been the same for about 30 years now. We use induction upfront, where we use high doses of immunosuppression. And then once, hopefully, we have put people into remission, then we place them on maintenance. And it is unclear what the appropriate time frame for induction is, but we have ideas. It is even more unclear what the appropriate time frame for maintenance is, but we have ideas. And we'll go over some of this stuff today. But now, this is beginning to change. So the first 2 lines are how we have treated lupus since the 1980s or 1990s. The induction phase, which usually lasts 3 to 6 months, we used to have steroids only, but then we started with cyclophosphamide. Then now we have moved on to MMF for a lot of patients. And if it were up to Dr. Masood, he would use only MMF. He really doesn't like cyclophosphamide. So there seems to be some childhood trauma there with cyclophosphamide, which we'll ask him next time. Now, maintenance, we need to go at least 2 to 3 years. And the agents that we use with some frequency are MMF and AZA. Some people use steroids for longer periods of time. And there are other agents available as well, which we can talk about. There are certain second line agents that we throw in at various places when we get into trouble. And over the past decade or so, you've had calcineurin inhibitors and rituximab come up. This is what Dr. Qureshi was talking about, where you're using multi-point therapy. And now the newer approaches to lupus are kind of turning this paradigm of induction and maintenance on its head. Multi-drug therapy de novo is beginning to take some hold, and there's some very good new agents coming out now. Voclosporin is finally, it looks like, getting close to getting approved. Obinutuzumab is a humanized anti-CD20 antibody, and then belimumab is an anti-BAFF or anti-BLyS agent, which is approved for lupus nephritis, but is not approved, which is approved for SLE, but not approved for lupus nephritis. but there's been a trial that was just reported in the New England Journal of Medicine last month called Bliss LN, and it seems to show some promise there. So we'll kind of work through some of this. So this is our first case, and these are all cases for discussion, so please feel free to jump in. This is a 22-year-old female, has arthralgia, has arthritis, has a facial rash. NA is positive, double-stranded DNA is positive, complements are normal. Creatinine is 0.6, urinalysis has 1 plus protein. She was started on some oral steroids and hydroxychloroquine and referred to the nephrology department. Her urine protein creatinine ratio is 600 milligram per gram. Her creatinine, like I said, is normal at 0.6. So how many people will biopsy this patient? No one will biopsy, everyone will biopsy. Jump in, guys. Dr. Aurangzeb, would you biopsy this patient? So there's no right. I'm sorry?
I don't think. I think I've just joined, and with data, I would like to observe. And what is she on any drugs at the moment for SLE of extrarenal origin? Or
She's on steroids and hydroxychloroquine, and that's it.
And she isn't on MMF, right?
She is not on MMF, not at this point.
All right. I think I would observe with the current medication, she is on steroids and HCQ. I think I will wait for a while.
Yeah, and I think that's very reasonable. That's actually what I ended up doing. But I just wanted to make a point that there are studies which have now started looking at this. And, you know, lupus is one of those places where my thinking about the place of biopsy has changed radically over the past 10, 15 years. I was very slow to get onto the biopsy bandwagon, but it looks like the more we learn about lupus, the more we need to biopsy these patients, because the histopathology may look very different from what the clinical picture looks like. So in patients with lupus who've got 500 milligram to a gram of protein, most people would agree if the proteinuria is more than a gram, we'll go ahead and biopsy them. But in patients who've got low-grade proteinuria, 500 milligram per gram to a gram per gram of protein, there is a fairly healthy sprinkling of class 3 and class 4s along with class 1 and class 2 as well. So you can identify some of these patients. So I did keep this patient on a very tight leash, just as Dr. Aurangzeb had mentioned. We checked her numbers 3 months later, and she now had about 1.2 gram per gram of protein. We biopsied her, and she actually had class 4 lupus, which needed treatment with aggressive immunosuppression. So creatinine and even proteinuria can be deceptive. Obviously, when you've got 500, 600 milligrams, it's kind of hard to make the case, but keep a pretty, so my threshold for biopsying has been going down as I'm getting older. So this was just to make this point that sometimes we can be fooled by what looks like a fairly benign picture. The tissue may be on fire.
Dr. Aga,
yes.
Were there any RBCs in the urine?
I would be lying. I don't remember. I don't remember. All I remember was there was protein. Sorry, it's a pertinent question, but I don't remember. I can make it up, but I don't want to.
That's okay.
Another thing, sorry, Irfan, quickly.
Yes.
So, if I don't know if you remember, but this biopsy, from what you're saying, is that at that point in time when you're presenting the case with these features, the patient actually has type 4 lupus on the pathology?
Not on this. 3 months later, when she had 1.2 grams.
Oh, I see. So was the complement still negative, by the way, at that time, and were they fixed?
No, her complements had dropped. In 3 months, the complements had dropped.
Yeah, so that was sort of the point. I mean, like, you might be obviously more aware with the recent data in terms of the earlier biopsy thing. Was that hold true with the normal complements, or is there any role of complement hypocomplementemia in terms of jumping to a biopsy versus simply?
Yeah, I think when you've got hypocomplementemia, you're more convinced that you're going to find a higher grade lesion. But the point I'm trying to make here is that you've got 600 milligram per gram of protein. That's probably not enough. But if you got about a gram of protein with a young person with lupus, you probably want to treat it, because if she's got class 3 lupus in there, which is kind of not obvious, and we don't treat that appropriately and aggressively, her renal outcomes start dropping. So the difference between class 2 and class 3 and class 4 and class 5 lupus is very stark when you look at renal survival. Class 1 and class 2 are almost flatlined. I mean, I shouldn't say flatlined, they're normal, whereas class 3, 4, 5 all drop very, very significantly. So the idea is to get on top of this as quickly as you can. I probably wouldn't still biopsy somebody with a creatinine, with a PCR of 600 make per gram. But if they are closer to a gram, I've started biopsying them. Mostly I find type 2 though.
Dr. Khan here.
Yes.
I have one question. At that time when she came in, initially we started on steroids and hydroxychloroquine. Did we thought about starting MMF at that time? Because she was having a kind of 0.5 gram of proteinuria and it can get worse.
Sure.
So
the question to ask is, what are we treating at that point? The thinking was that she probably has class 2 mesangial lupus. And at that point, we just decided to follow her. And you have to, when you're trying to put somebody on immunosuppressive therapy, combination immunosuppressive therapy, you have to define the lesion, and a biopsy becomes important. Biopsy is very important in lupus, and it surprises you. The more you biopsy, the more you're surprised. All right, so this is the, I'm sorry, go ahead. Somebody asked a question?
No.
Okay. So there was, this is the next case. This is a young female who was diagnosed with ITP in 2013. So she was given steroids, rituximab, and cyclophosphamide, all by her hematologist. She obviously had no kidney issues at that time. She went into remission and remained in remission for about 5 years. In 2018, she had cutaneous and rheumatic symptoms ascribable to SLE. She was treated with steroids. She then developed proteinuria. She came to a nephrologist, was biopsied. She was class 4 lupus with some crescents, but these were defined as less than 25% crescents, not a lot of IFTA. Kidney function was normal. How would you guys treat her with this? How many people would treat her with cyclophosphamide? How many people will treat her with MMF?
I would go with cyclophosphamide. It's a proven drug since long time, and this is active. Does a patient have? Yeah, she have active lupus nephritis. I think this will be my kind of. I'm not an expert, but.
Okay, so and I'm sorry, I didn't catch who was making that opinion. Sorry, sometimes it doesn't show up on my.
Yeah. Yes, I'm Dr. Khan, one of the fellow right now.
Okay, Dr. Khan wants to give cyclophosphamide, not
steroids.
Okay. Anybody else with any other ideas? Any other opinions? Dr. Aurangzeb, I know you're itching to give a rituximab. No, I'm just kidding. I'm just kidding.
Well, that's not true. But the thing is, crescents are there, and I think the cyclophosphamide is the first option and need to be discussed. But if the patient refuses to take cyclophosphamide due to some fertility or sterility reasons, then we have some other option.
Okay, so when we talk of induction agents, it looks like we've got 2 opinions that support cyclophosphamide. Nobody is going to give this woman MMF. She's got.
Why not MMF?
Normal kidney function. She's got, class 4 lupus, but she's got some proteinuria. So why not MMF? Why cyclophosphamide?
I think MMF is on my priority list here. I know Dr. Masood is not here, but
I mean, he would be going apoplectic by now.
I'm leaning.
I think, just correct me if I'm wrong, how many crescents were there in the renal biopsy?
Less than 25%. So not a lot of crescents. It wasn't diffuse crescentic disease.
So
there was some crescents there.
So Dr. Agha, I mean, the thing is that we have to treat it as class 4 lupus.
Sure.
So I mean, one key point you mentioned, the third bullet, non-compliance with treatment medications.
No, we didn't know about that yet. So she demonstrated that later, after we had already put her on treatment and she had actually achieved remission. She was non-compliant with maintenance therapy. So she went into remission, and I'll tell you what we did with her. She went into remission, but then she was non-compliant with taking her treatment for the.
Oh, that's why I was thinking, because since you mentioned that point, I mean, the MMF versus rituximab thing, I would have probably treated it with rituxan at this point. You know, even with cyclophosphamide, even with the IV, you need 6 months compliance, which I have personally seen far worse than a 4-dose or 2-dose rituximab therapy.
That's very fair. So, okay, well, so there's 3 agents now been talked about as possible induction agents. The first is cyclophosphamide, the second is MMF, and the third is now coming in rituximab. And so let's kind of work through that, but just to let you know what we did.
One thing regarding this rituximab, are we talking about rituximab alone or in combination with MMF?
Well, I don't know. I think Dr. Khan will be able to help you with that because rituximab was his idea. I'm not taking any blame for that. Dr. Khan, would you want to do rituximab alone, or are you wanting to do rituximab with steroids, or you want to do rituximab with MMF in this particular situation?
I'm asking this question because after LUNAR trial, usually that rituximab is thought in combination with MMF. And sometimes when we are talking about induction in a crescentic lupus nephritis with rituximab, I think it's not rituximab alone. It's with MMF that it has been tried successfully.
Yeah. So I think the only variations on that is then the rituximab protocol, they used no steroids. So that was the variation, but they did use MMF with rituximab, whereas in LUNAR, they used it with MMF, so and the steroids. But anyway, so just to kind of cut through some of the discussion here, she was given induction with MMF and steroids, and she actually achieved full remission. And then we put her on MMF maintenance, and she vanished. And then she appeared again in 2020. She had a flare now. She had acute kidney injury. She had interstitial infiltrates, which looked like pulmonary hemorrhage maybe, or lupus vasculitis, or a pneumonia. Her ANA was positive, dsDNA was very high level positive, complements were both down. How would you treat her now? So she's a complete relapse because she wasn't on maintenance. Maybe she would have relapsed anyways. So how would we treat this patient now?
Hi, Dr. Aga, this is Bilal. Can you elaborate on pulmonary involvement? What sort of involvement was that?
Yeah, so she was coughing, was short of breath, chest x-ray showed interstitial infiltrates, CT scan showed diffuse alveolar infiltrates. It looked like she may have pulmonary hemorrhage, but when we did the bronchoscopy and lavage, she didn't have hemorrhage. So it looked more like lupus alveolitis. She didn't have infection.
Yeah.
So would you do a biopsy again, a kidney biopsy again?
And what would you want to do with a kidney biopsy at this point? Her creatinine was 0.6. I'm just asking, I'm not saying yes or no, but I'm just trying to think about the thinking here.
So you said like this flare has AKI.
Mm-hmm.
How high
yeah, no, I'm sorry. You're correct. Her creatinine was in the 2s at this time. Her baseline creatinine was 0.6. That is correct.
And then this was like, do we know this is like a chronic elevation of the creatinine, or this is all acute?
We don't know because she has not been in for over a year.
Mm-hmm. So that's one of the, I think, point that, you know, what you brought about the concept of be liberal with lupus biopsies and rebiopsies. And I think we do that. Any patient, anytime you have a doubt whether this is burnout lupus or there is still a lot of life left in the kidney, I have done second biopsies in some patients. Actually, the voclosporin trial mentioned, I think there was a patient I had to do second biopsy just for the sake of trial. And we found active lesions when she had no disease on the urine or something. So I think that's why I just asked, like, you know, you want to know whether this is a burnout lupus from some chronicity or this is all acute. That's why I asked.
I mean, excellent point. She was rebiopsied, and the biopsy looked like it's a mirror of the previous biopsy. Okay. Diffuse proliferative lupus, crescents, not like diffuse crescentic disease, but crescents. fibrosis was still 20 to 30%, so not a lot of fibrosis. So
then
surprisingly
can I ask,
good kidney.
is that the like, you know, in Pakistan, do you have a low threshold to rebiopsy these patients?
No, so the threshold would be quite high. I'll let the others answer because it's very difficult to convince a patient to undergo one kidney biopsy, let alone do another biopsy, let's say, just to see what the progress is like. But I'll let the others answer.
Anybody else wants to?
Yeah, that's true. The thing is, there needs to be a lot of counseling going on. I think biopsy is covered in insurance back in USA. In Pakistan, it's not being covered. Even in government sector hospitals, the biopsy has to be sent to an outsourced lab, and the people have to pay for that. So that's one of the reasons. And on the other hand, there is usually सीना बसीना knowledge मरीजों के आपस में जा रहा होता है, जिसके अंदर biopsy is considered to be something really dangerous. So the thing is, we have to go through different patients on basis of their understanding. We do want to do a renal biopsy, that's true, but mostly we are unable to do biopsy frequently.
Okay. One more point, you know, I want to ask is, Dr. Aga, is what was the CBC at this point? Was there any hematological findings at this point?
She was mildly anemic, but she didn't have any severe thrombocytopenia or anything like that, which was kind of interesting.
Yeah, because I mean, I don't know what your opinion is about this, or maybe the evidence behind rituximab versus cyclophosphamide, and in terms of the degree of anemia. I mean, one point is obviously the association pulmonary findings. The second is prior exposure to cyclophosphamide in the past. Never been exposed to rituximab. I mean, I've had cases in the in past, not lupus, but for example, a membranous case where they had patient with severe anemia, hemoglobin of 6s and 7s, where we decided not to do cyclophosphamide. And then the other is the fertility question. Actually, I really wanted to ask that before this meeting ends, because I have another case, a young guy with treated with cyclophosphamide with crescentic IgA. So I guess, related to Pakistan, might not even be, I don't know what the feasibility there in terms of fertility preservation in young people, in terms of ova preservation or sperm preservation. And when you're choosing IV cyclophosphamide therapy for, these women with childbearing age. And sorry, one last comment was about the race, African-American. Was there concern of ApoL1 in this case?
African-American, it's a very valid concern, but we do not have genetic testing available at this point.
All right.
Let's suppose if the genetic testing was available and that patient is turning out to be positive. So would you treat something differently?
No, it doesn't change the treatment, but it tells us that, we have to keep that in mind, because Dr. Qureshi has brought up an important point, which was kind of our concern, that this patient has already received cyclophosphamide. They're young. They've already had one exposure to cyclophosphamide when they were a child, or, relatively younger. And now we're going to give them, we're thinking about doing something more. So we got to keep that in mind. So given all of that and all the concerns that have come up, now this person is in the hospital taking very shallow breaths, and their kidney function is off. Creatinine is in the 2s now. Markers are up. Biopsy shows lupus. How would we want to treat her?
The cyclophosphamide dose, what is the cumulative dose of cyclophosphamide that the patient has received?
We did not have that information. She did receive, she said, at least 3 or 4 infusions. So I'm assuming she got 3 or 4 grams at that time. This was in 2013, so some time ago. I do not have those records.
So probably, I think, in controversial question, but a combination of MMF with rituximab and steroids.
Okay. That's a reasonable idea. Dr. Qureshi, what would you do?
Yeah, I would probably, again, various factors, again, this is a pretty reasonably complex situation, given all the prior history primarily, and the history of non-compliance with oral treatment. So I would probably lean towards rituximab treatment, basically.
Okay. Anyone else? Umar, what would you do?
I think I'm leaning towards the, maybe we can start with the rituximab and then use, MMF and steroids and, as our helper, because this patient has severe pulmonary involvement. So do we have the lupus anticoagulant?
Negative.
Okay.
Would Plex have any role in there?
That's why I asked the question.
If the lupus anticoagulant were positive, or if she had open hemorrhage, maybe would want to do that. But I think short of that, maybe not a very well-defined role.
And what about belimumab after BLISS-LN in this case?
Yeah, so belimumab in an acute situation like this, probably not the best agent. That has more to do with keeping the milieu right once you've given some depletion therapy. So especially if you do use rituximab, then there's in the secondary lymphoid organs, there's a very quick proliferative response in the germinal centers, and that's where BLISS and BAFF inhibition seems to work a little bit better. So I don't think in the acute setting BLISS inhibition is going to help that much. So just to kind of tell you what we actually did, after discussing everything and looking at the pulmonary involvement, we actually gave her a pulse of steroids and did give her 3 doses of IV cyclophosphamide monthly, and then switched her over to MMF. She has gone back into full remission. Believe it or not, creatinine is 0.8 now. Proteinuria has come down significantly as well. So this worked out. We thought another 3 grams of cyclophosphamide is probably doable. But these are the difficulties, and I don't think I can fault any of the other regimens as well. You can try whichever way you want to see that patient go and see what agent would be best for them. But these are things, although there's a lot of data, there's still a lot of discussion. So I would spend about 10 minutes very, very quickly. So I'm going to breeze through some slides here to kind of just bring you some context of how we have ended up where we've ended up. So the treatment of lupus really started in the late 50s and 60s. So in 1957, there was the first case series of cortisone, 50 milligrams daily, being used for lupus, 10 patients, not good outcomes. Then in 61, we started using the little pulse doses of that time. In 64, we kind of started moving towards higher doses of prednisone. And by the end of the decade, so by late 1960s, prednisone 1 mg per kg was the standard therapy. In the 70s, studies started coming out on whether using a cytotoxic agent like cyclophosphamide or chlorambucil, etc., would help. And all the studies that used steroids only fell below the line of identity, and the studies that were using steroids and immunosuppressives tended to do better. So this prompted the NIH study, which is a very, very murky study as far as methods go, but they had 107 patients and they put them into 5 groups, and suffice it to say, if you had IV cyclophosphamide or azathioprine with cyclophosphamide, these guys did better than everybody else, and steroids alone did really, really poorly. So in the late 1980s, the state of the art was prednisone is good, cyclophosphamide in combination is better. At that time, because of the New England Journal of Medicine publication of this NIH trial, IV cyclophosphamide was considered the way to go. And just to make a point that the original NIH study had used IV cyclophosphamide every 3 months. The regimen that eventually emerged was an induction phase of 6 monthly doses of cyclophosphamide followed by a maintenance days. And that's the paradigm we tend to adhere to now. And then there was a study looking at oral versus IV cyclophosphamide, and the issue here is cumulative dosage, and you tend to give more cyclophosphamide if you're using it orally. So most people would adhere to cyclophosphamide intravenously. And then the Euro-Lupus trial, ELNT, was published somewhere in the early 2000s. And what they compared was high-dose IV cyclophosphamide, sort of like the NIH protocol, but abbreviated the first year. And then low-dose IV cyclophosphamide, where you get 6 fortnightly doses of cyclophosphamide, just 500 milligrams. So a total exposure of 3 grams, and the outcomes were not different at all. So the number of patients that were free of renal failure and were about the same, and the number of patients who were free of severe infection, low dose did much better, as you would think. So this is, the origin of the lower dose Euro-Lupus protocol. The only thing was these were all North European descent patients, so they didn't have the tough patients that we have. But by 2000, people thought that steroids were good. Steroids with IV cyclophosphamide is better, and perhaps we can use IV cyclophosphamide in lower doses on the Euro-Lupus schedule in patients with favorable clinical and disease characteristics. So then starts the MMF era, and this is what I call the Chan 1 study, the first study that came out of Taiwan, or Hong Kong, I think, I'm sorry. So they randomized people to oral cyclophosphamide plus steroids versus oral MMF plus steroids. And the MMF was shown to be non-inferior to cyclophosphamide. So this kind of was surprising, because at that point, the mantra was that cyclophosphamide is the only way to go. So this put MMF on the map, but this was in an Asian population. So the study was reduplicated, sort of, in a US population. So this is the Ginsler-Appel study. They had about 140 patients with active lupus, 3, 4, 5, and they used a standard dose of MMF, 1000 BID for induction with steroids with a taper. And the IV cyclophosphamide was based on the NIH regimen, so 0.5 to 1 gram per meter square monthly for the first 6 months. And what they found was that the MMF did pretty much as well as the intravenous cyclophosphamides. It was not inferior. And so there was a larger trial that looked at the same question. This is the ALMS trial. This had about 370 patients. And again, in these patients, overall, there was no difference between MMF and intravenous cyclophosphamide. Asian patients, no different. Caucasian patient, no different. And I'm sorry, I've got the wrong graphic for this. If you break this other down into Hispanics, actually, MMF was statistically superior in Hispanic people, and also in African Americans and Black patients. If you used mycophenolate, that was statistically superior to intravenous cyclophosphamide, which was very surprising. So this, put MMF on the map. It was not inferior to cyclophosphamide in these patients. So with this information, when we battle between IV cyclophosphamide and MMF, actually the data shows that as induction agents, they're about the same. Now, this shouldn't blind you to clinical judgment. So somebody very, very sick with diffuse crescentic disease and maybe pulmonary involvement, it is perfectly fine to consider cyclophosphamide in these patients. But if you've got somebody with diffuse lupus and they don't have bone crushing disease at that time, MMF is should be your first agent. So with this, we come to this next patient. This is a 30-year-old white female. She had arthralgias and rash, proteinuria with a creatinine of 1.4, baseline is 0.8, DNA is positive, ANA is positive, complements are low, biopsy is class 4 lupus nephritis. She was started on MMF 3 grams a day and prednisone 30 milligrams a day. Now it is 3 months later. So this 30-year-old white female who's got diffuse proliferative lupus nephritis, what is her risk of death because of SLE? Does anyone know what kind of risk of death SLE in this situation? Even class 3 lupus, what kind of risk of death it confers? Anyone want to take a stab at that? It is 6 times more than the general population. What is her ESRD risk at 10 years? With this picture, what is her ESRD risk at 10 years? Anyone want to take a guess at that? It's about 30% based on the data. 30% of these people will be on dialysis in 10 years. Now, I said that it's 3 months later. How do I define, what do you guys use as response? What do you describe? If you're treating this patient in your clinic, what would you describe? How would you define a complete response? When will you say, I got it, this patient has responded, so I can now scratch my head and start thinking in terms of maintenance therapy? So what is a full response in lupus nephritis, and what is a partial response in lupus nephritis? Who's going to take a stab at that? Anyone? I mean, and this is not a viva voce question. I'm just asking what your practice is. What do you define in your unit when you're treating these patients? Omar, how do you define your full response?
Yeah, I mean, I don't want to deflect the question, but I definitely want to hear what our colleagues see, in Pakistan are
absolutely
doing. And besides maybe Dr. Ali and Dr. Aurangzeb, sorry, no offense to you. I just want to hear from other folks as well.
That's what I'm trying to do. And I'm very sorry I don't remember the names of everybody who are on the panel. I'm just trying to get people to contribute, and because we want to learn from your experience as well, that, what is it that you do? I know what I do, but I want to learn what you're doing.
So Dr. Mateen, can you tell us or help us understand how you manage this?
Thank you, Dr. Umar. Regarding that of the complete remission, I actually did not know the exact answer of this, but having a proteinuria of less than 500 milligram with the improvement of the complement, decreased level of the complement, and also having if the patient having a renal dysfunction, the improvement of the serum creatinine as well. So I don't know the exact answer.
Most studies have used that. Is there anyone who's using a different standard for complete remission? So complete remission in most studies has been defined as a proteinuria less than 500 milligram per gram and return of creatinine to baseline. So in this particular patient, if her creatinine went back to 0.8 and proteinuria went down below 500 milligram per gram, that would be considered a complete response. A partial response would be partial. So essentially your proteinuria drops below 3.5 grams. So if it was more than in the nephrotic range, it drops below the nephrotic range, but generally it's below a gram. And the creatinine hasn't returned back all the way to normal. So that's mostly how you would define, most studies have defined complete versus partial response. So in this particular situation.
So I wanted to quickly ask you about this the partial and complete. So basically there are two things, right? The proteinuria and the serum creatinine, the GFR. So is it true for all glomerular diseases? I mean, I guess, probably a more experience with membranous, but that certainly holds true for membranous because the degree of proteinuria is far greater often there or with FSGS. But in these kind of patients with, first of all, this patient had a baseline proteinuria of 800, which I don't know what that is from. Maybe there was sort of a subacute lupus going on or something. So the
baseline is the creatinine that's creatinine of 0.8.
Oh, okay. So they had no prior proteinuria, I guess.
No, not that we know. We had no information of that.
Okay, so in this
we had a renal panel, no UA.
So one proteinuria criteria, as you said, subnephrotic, sub less than 500, or sort of this, what's now called moderate albuminuria range. But in patients who are not nephrotic at all at presentation, does that same holds true? Like it should still be less than 500, or is it a more stronger?
For a complete remission, the studies, the way they have parsed it is for lupus. So, you're right that, this is kind of the standard mantra we have for most of the GNs, proteinuric GNs. But there are some studies, especially in FSGS, that hold to a higher standard of 300 milligrams per gram. But, that's kind of a little bit of a variation in there. But the idea is if you're really knocking the proteinuria down well, that's complete remission. But if you've knocked it down somewhat, but not completely into the full response range, so less than 500 or less than 300, then that's docked as a partial response.
What about what was the class 4? What was the chronicity score in that case?
I don't have that information off the top of my head, but that's kind of, it's active lupus.
I'm asking this question. What is the role of glomerular hematuria monitoring in this case? If it was a pure active lesion and there wasn't any chronicity.
So I don't know if you take it into consideration, but I'm just going by what the various studies have used as their criteria for a response, and we were just trying to dock that.
I think that's a good point, because maybe differentiating nephrotic diseases from nephritic ones, and then the nephritic ones, maybe hematuria might itself be a third criteria for remission.
Well, that's true, but that's not been demonstrated in lupus, right? So when you're looking at a criterion, it is meant to demonstrate something, that if this is present, this is going to impart that much of an outcome influence in that disease process. So when you're having hematuria, that does tell you that there's some glomerular response. But I think the only glomerular disease in which hematuria is now being demonstrated to have an outcomes influence, and therefore is being included in the decision-making process, is IgA nephropathy.
No, that's true. That's what I was thinking about.
Right. So I don't think that's been demonstrated in lupus. If we can demonstrate that, we can add that. Similarly, low complements, high complements don't distinguish that outcome. What has really distinguished that outcome is proteinuria and kidney function. So those are the two things that are generally used. Now, do I look at everything else? Absolutely. But all I'm trying to say is, when do you say that there's been complete remission of the lupus process? And this is what it is. So
I think activity of the urinary sediments should be considered upon. And I totally agree with the data that you have just mentioned. But if the patient was having an active urinary sediment, and later on the microscopic hematuria has gone away, and the proteinuria is 700 milligram per gram, it may be a scar proteinuria.
Okay, yep, sure. But I think this kind of segues into another question that is actually now being asked more and more, that should we be rebiopsying these patients to stratify treatment? So a lot of people are beginning to do that now, that they are going to they rebiopsy and see where things are. But just in the interest of time, because we're kind of almost at the 2-hour mark. So essentially, what we do in these circumstances is that somewhere between 3 and 6 months, we see what is the degree of response. And if we find that the patient has gone into full remission, let's say if that happens at 3 months or 4 months, then at that point we start shifting into maintenance mode. And the maintenance mode is generally continued for 2 years or 3 years. So if they're completely if the disease is completely under control, then at 2 years or 3 years, we start weaning off immunosuppression and take it off. But in many lupus patients, I have kept them on immunosuppression for long periods of time, because lupus relapses and also continues with subclinical activity. So I'm going to jump over some of the other cases because we are getting way behind. I wanted to quickly touch on membranous, which is class 5. Now, in all the studies that we have talked about, these have been lumped together. Pure class 5s have been lumped together in all the other induction and management protocols. But it looks like membranous is a slightly different animal. So pure membranous without proliferation does not confer the same renal risk that a proliferative lesion does. So the outcomes on these cases are a little bit better. We still treat it pretty much the same way, but and these are about 20% of all cases of lupus. So I'd ask all the panelists, do you treat membranous differently in any way? Is there anything else that you do differently now with the emerging data, or do you treat these patients the same way?
We have a low threshold to start calcineurin inhibitor, cyclosporin, for pure membranous, especially for maintenance.
Yeah, yeah. And I think that's kind of where the science of this is going. This is one of those areas where early start or early introduction of calcineurin inhibitors, along with other therapy as part of the multiple multi-point inhibition therapy is becoming the vogue. And I actually have had very good results, and these are anecdotal, my own patients, because what I've found, like in membranous, otherwise membranous, pure membranous pathology is a slow ramp on, slow ramp off disease paradigm. And these patients take a long time. So this particular patient that I was going to present, but I'm going to skip off because of time, was treated for 9 months with slow reduction of her proteinuria. But then we introduced calcineurin inhibitors with very good results. And so I've started using CIs earlier and earlier. Sometimes I open up with them. Now, this patient also had a very interesting phenomenon, which I'll just spend 30 seconds on, and then we'll kind of ask for comments and call it a night. So she had a very high titer ANA. Her ANCA was positive in a P pattern on indirect immunofluorescence, but was negative on the ELISA, so there was no MPO or PR3 positivity. And so the reason that happens is that on an ethanol fixed specimen, when they do the indirect immunofluorescence, the ANA actually tags the PrEP. So it's actually an ANA causing a false positive ANCA test on the cell prep on an ethanol fixed specimen. But when you check for specificity, and it's usually reported on a PNCA fashion, but when you check specificity through ELISAs, and you find that the MPO and PR3s are negative, so sometimes you just disregard. So in this particular case, I would not put any credence to this ANCA test. This is a false positive ANCA, probably driven by the high titer ANA. So I will stop here. I'm sorry, we still have to do better time management, but if there's any questions, comments, future discussion points when we discuss lupus again, if there's other things that you want included, we'll be happy to talk about that. Sorry, Dr. Aurangzeb, I wanted to talk about LUNAR and rituximab, but we are dreadfully short of time today.
I just wanted to ask, the reason for using CNI, I think that is with MMF, right? And,
that's correct.
The reason for using CNI and specifically tacrolimus is blockage of interleukin-2.
Yeah, so essentially it is a little bit of that and a little bit of blockage of the immune response itself, and to affect the B and T cell interaction. So CD4 cells, like we talked about last time, I think, when they proliferate as a result of their interaction with antigen presenting cells, they can run different programs. And if they run the BCL6 program, they turn into T follicular help cells, and T follicular help cells, so the TFH cells, actually crosstalk with B cells and lead to the germinal center reaction. So the idea is that using these may actually, using the calcineurin inhibitors may dampen down the T cell arm of the immune response, which is perpetuating the autoimmunity.
It has nothing to do with the cytoskeletal rearrangement, the physical effects of CNIs on the podocytes. We are not expecting the same kind of relapse that we expect in terms of membranous. Once we pull out,
this is different. Yeah, this seems to be a true immunological synergy.
Okay, of course, I wanted to talk about LUNAR and the air, but the time is short. So,
any other questions, comments?
Yeah, I think this was a great discussion, Dr. Agha, and hopefully, I mean, everyone will have their own take-home points. I mean, this whole, maybe I guess, I don't know, is there a third session on this lupus again, or is this the final one?
No, I think we had 2 sessions planned for lupus, but we'll try to, we'll probably do this in another 6-8 months, and we'll try to, learn from, how the discussion went on this one to kind of make it a little bit more channeled. I think the discussion part is so fascinating that, we sometimes lose track of time, but we'll have to use, I think we had Umar designated as our timekeeper, so we'll have to give him the gavel this time so he can come down on the time a little bit better.
And I took most of the time today. I apologize.
No, you didn't. That was a great case. That was the best part of it. There was a lot of good discussion that came out of it.
Maybe we can have more sessions and maybe less cases so that we have more time for discussion. But certainly lupus is such a controversial, I mean, complicated and that it's worth the discussion. I mean, sort of one take-home point, which at least I have, is this whole point about Umar's initial case, where they have an additional antibodies positive in the setting of pure lupus. Would that be considered as a second disease, or would that be considered simply as greater severity of lupus, which has to be dealt with a two-gun approach up front? And that's one thing. And the other is obviously the mechanisms of different drugs, B cell, T cell, and then maybe, I don't know if there's any studies on as someone's mentioning earlier, about the specific effects of calcineurin inhibitors on the podocytes, and people who have a higher proteinuria, more proteinuria subcohort of lupus patients, where we can consider that maybe as, if not induction, but in the maintenance regimen, along with MMF or instead of MMF. But yeah, that's some of my sort of take-home points from this.
Very good. No, all pertinent points. Very good, everybody. Thank you for bearing with us for another 2 hours, long hours. I was hoping that we would be more time efficient this time, but we'll get better as time goes along.
Yes, Dr. Irfan. Sorry, Dr. Irfan. Just want to having a 2 aspects of lupus. One is a kidney transplant, and the other is pregnancy related with that of the lupus. And if the patient, a female patient who is in a remission for in a lupus and want to conceive, there may be some discussion on kidney transplant and as well as the.
We will certainly, those are both good points, and I'll try to put them together in the next talk. Absolutely. Okay. Both very good points.
Yeah, I think, and with that, I know we have a pessimistic approach toward the LUNAR trial, but I have something to say about it. If there is a next session on SLE, I think there should be a part on the role of rituximab too. I know it's controversial, but there are some sides of it that are not really applicable to Pakistan. For example, 3 gram of MMF that was in a LUNAR trial. I think my practicing physicians in Pakistan, they'll tell you that the tolerability of MMF above 2 gram per day is a little difficult in Pakistan. So usually what we are using is 2 gram and a maximum of 2.5 gram, and very rarely 3 gram MMF is used. So are we really comparing apples versus oranges?
No, I think those are all very reasonable points, and I agree with you that there's a sub cohort of lupus which responds better to rituximab, responds well to rituximab, and there's no reason for us to assume that lupus is a one and done pathology, and there's multiple types of antibodies, and I'm pretty certain some of them do act as NK antibodies. So the pathology is different from the traditional lupus pathology of fixing complement through antigen antibody mediated complement activation and then structuring an immune response. So I think it is those patients that may actually respond well to a rituximab-based regimen. And since we lump them all together, it's hard for us to figure out which bucket is which at this time. But as we get better at finding ANCAs, as we get better at defining and parsing pathology a little bit more carefully, we might be able to tease these apart a little bit, but it's very hard to run a trial on that. It's very, very difficult based on numbers and logistics and all that. So this will always be a clinical decision. So the trials are going to be like your lunars and rituximabs, where you drive an idea and try to see if you can get a signal.
I think I will propose a motion to adjourn.
One thing I would want to say that, we were initially planning to do IgA nephropathy next, but Ahad wanted to have a transplant discussion on, correct me Ahad, what it was HLA and antibodies and stuff. You wanted to have a conversation on that?
So there's a popular demand to talk about HLA typing and how to read these HLA tissue typing reports that come in to see what is a match, what is a mismatch. If you can just look into that, because that would be hard. That would look into immunology as well.
Very good. So and I think we had set apart the 15th of November for that, right? Because I'm not available the first week.
Yeah.
So we'll do it on that.
Absolutely.
Very good. So next one would be a transplant talk, and then we will get back onto our lupus, not lupus, our GN schedule and go and do IgA nephropathy or something. All right. Thank you, everybody. Have a good day.
Thank you so much. Thank you.
Thanks.